Hi, my name is Frank LoVecchio. I am a physician. I practice in Phoenix, Arizona. I'm going to talk to you about managing patients on opiates and when to taper off. I started my career, I guess, in emergency medicine, and I still continue to practice emergency medicine, but afterwards I did a fellowship in toxicology and became boarded in medical toxicology, addiction medicine, and a little bit of forensics. Along the way, I got a master's in outcomes research, really to study some infectious disease stuff and also opiate, and to figure out best practices and to research why people get addicted and maybe how to prevent it. So I'm very passionate about this topic. I'm excited to talk to you about it. So today we will be talking about managing patients on opioid analgesics, not necessarily how to treat their pain, but to get the balance between side effects, when to taper off. When do I stop these medications on my patients? And we'll talk about that. You never really stop them. If they've been on it for a long time, you usually gradually go down. So tapering off the medication when the benefits of opiates no longer outweigh the risks. Okay, so very, very important. I know many of you guys are familiar with the CDC guidelines, and if you recall, they came out once and people were pretty aggressive about saying, opiates, we're only going to give them for 3 days max, stop everything. And people were like, I've been on opiates for 5 years, you just can't cut me off. And then they came back with a revision and said, hey, those acute cases, when you go to the emergency department, you're naive to opiates, keep it under 3 days, short and sweet. But the longer ones, if people have been on it for years or months, you have to go slower. So they feel as though that correction was needed. I'm going to give you a case, and the case is Mr. Obvious. Okay, you can tell by the name that Sam Obvious is going to be screaming that he is misusing opiates. So Sam Obvious was found altered outside a restaurant near closing time. He was minimally responsive to painful stimuli. Somebody came by, yelled, wouldn't wake up. And he might have looked like that. He's got a cigarette in the side of his mouth. He's got some drug paraphernalia next to his body. His pupils are pinpoint, but he's breathing spontaneously. Now, there's no argument whether you give this guy Narcan or not. If he's breathing okay and his sats are okay, you don't know what his saturation is, but if he's breathing okay, it's probably best not to give him Narcan. And the reason, of course, is that you could precipitate withdrawal. And if you precipitate withdrawal, that could be potentially painful for the patient and much more difficult to treat as a patient. So I always like to say, if you're going to give him Narcan, try to give the least amount possible just to kind of make him breathe spontaneously, make him breathe enough to maintain good oxygenation. Of course, it's easy for me to say without a pulse ox or other data, but if you get his respiration rate, above 8 to 10, and he doesn't look like he's in respiratory distress, you're probably okay. So in the emergency department, he started to wake up and reported that he'd been partying for up to 2 days straight, okay? And he's a little off with the dates. He's very, very confused. You did check a urine drug screen. It's a whole argument whether you check a urine drug screen or not on these patients. But this patient was checked positive for methamphetamine, fentanyl, lorazepam, and marijuana. And he said multiple times that he just wanted to sleep, be left alone. He wasn't suicidal. You did your best assessment on him multiple times throughout the day. You tried to do it as he sobered up and tried to get a more valid examination. And all this urine drug screen tells you is that he used those drugs. He used methamphetamine within the last 72 hours or so. He used fentanyl, one could argue in the last day to 3 days, depending on, how much he took. He used lorazepam probably within the last day or so, and he used marijuana, at least in the last 72 hours or so. So it doesn't really tell you what he was high on. You probably should have maybe you got an alcohol level also, and if you got an alcohol level, that can more accurately tell you how long it's going to take for him to get rid of the alcohol and metabolize it. So the urine drug screen just tells you yes, no, i.e., yes, you're pregnant, but it doesn't really give you the quantitative number, okay? I find these little pictures fascinating, and some of the authentic sort of M30s there, if you see M30s, what they look like, the blue pills there, and we see the Xanax, we see the counterfeit ones. Of course, Xanax is a benzodiazepine, but what these pills were meant to do, the blue ones, and some patients will come in and say, yeah, I use 10 blues a day, 20 blues a day. and I think I'm cool and I catch up with the lingo. And by the time I catch up with the lingo, it's, moves forward. It's not a cool hip line anymore. But what they tried to do is make these pills look like OxyContin 30 milligrams. So if you look up OxyContin 30 milligrams, I've done that for you there, the real ones. And if you look up the real ones, they look very, very, very similar to the fake ones. One of the things I found, just for fun, when I'm working with residents or something like that, and the patient will have a bag of them, I'll show them how easy it is to take off the blue covering. So lots of times you could just scrape it across your arm. I wouldn't recommend that, or just wash it very quickly. But scraping it across like the bed sheet or something like that, the blue stuff will come off right away. And once you do that, almost always you have fentanyl, okay? The real ones don't really scrape off that easily, the real OxyContin. Hopefully you're not seeing too many of the real OxyContins either. So fentanyl, though, is in these pills. So why did they do that? Well, it turns out that if you put fentanyl in there, enough fentanyl, you can mimic oxycodone. Now, who gives fentanyl oral? When's the last time somebody said to you, give that patient, 1 milligram or 100 micrograms of fentanyl oral? Almost never. I know some of you guys are shaking your heads saying, well, we give fentanyl lollipops, we might give drops. But the reason why we don't routinely give it, it's very, very sporadic with the absorption. Another way to say that is, I took fentanyl by mouth, I absorbed 7%. You absorbed 9%. And somebody else absorbed 14%. And you can see that you don't want drugs like that, especially drugs that, a little can do a lot of damage. So you don't want something like that. But in general, the dose of fentanyl that, people have accepted that can kill you is about 2,000 micrograms or 2 milligrams, okay? Now, that's kind of a lot, but on average, if you look across the United States, now this is DEA seizures, the DEA get some drugs and they run them, and they run samples of them. When you look at those, about give or take, 20% will have greater than 2 milligrams required to kill somebody. Okay, so why are people not dying left and right then if they just use one of these tablets? Well, they're kind of cheating a little bit. What they're trying to say is if you took the 2 milligram tablet, you were naive to it, and then injected it, that would cause a problem. A lot of these patients, what they do is smoke them. And, if there's one good thing about smoking fentanyl as opposed to shooting it IV is obviously, smoking, you're less likely to get infectious disease, hepatitis, HIV, etc. But you probably stop when you're really high. So you take the fentanyl tablets, you put them on a sheet of aluminum, you take a torch, okay? Something more powerful than a lighter, although you can use a Bic lighter. You typically have to use a few of them. And then smoke starts coming up. And you usually have a glass straw, and you get the glass straw and you kind of inhale the smoke. And almost as fast as injecting it, it goes into your bloodstream. So now when you're really high and sleepy, what's going to happen? You're probably going to drop it, okay? I know that for a fact because I work at a burn center, one of the busiest burn centers in the Southwest, and a lot of people come in with little burns to their lower extremities. Sometimes I'll find a person who's, has pinpoint pupils, altered mental status, and, we're kind of disrobing the patient, and we see like a torch that's often used in the cooking industry. For those of you who make creme brulee, or something, or want to blacken the top of their fish, they take these little torches and go on top. Well, that person is probably not a chef. He's probably smoking fentanyl or smoking blues. Okay, so this guy is so obvious, and if he's your patient and you found out about this, you need to intervene. You need to do something. The intervention could be, anything from dropping him out of your practice, but assuring that he has, a good follow-up or somebody else to take care of him, or at least having, a very, very frank, honest conversation with him. For me, this is pretty obvious, hence his name, okay? What's not so obvious is this other patient, and she's Mrs. Subtle. Mrs. Subtle came into the emergency department for lower back pain. She says she's got a history of chronic back pain. She states she's got an acute exacerbation. She's here from out of town. She's visiting her grandchild, lifted up the grandchild, and then now has back pain. She describes her pain as 10 out of 10. She'll tell you that maybe it's shooting, etc. Her examination and vital signs are unremarkable. I think we can't forget these are still patients that you need a thorough examination on. You need to think about this wide differential that could be associated with back pain. In the emergency department, we differentiate back pain from more life-threatening things like, aortic dissections, abscesses, et cetera. So just think about that when you evaluate these patients. Why are they here now? Is it worsening of the back pain or just chronicity? Now, she requests an opiate refill for the weekend. She said, I'm kind of out of it, et cetera. Her physician is unavailable till Monday. And a lot of you guys right now I see are nodding your head because that is a common story, okay? They say that they're out of their medications. So what do you do? What do? You just take their word for it? Do you do a drug screen? Do you do labs? Do you ask family members? Do you call their doctor? And it's not like the old days. It's very, very hard these days to get a hold of somebody's primary care doctor. I mean, you could try your best, especially if they're out of state or something like that. It gets very, very difficult. So what the feds have done, what our states have done, is develop this thing called a PMP, okay? And PMP stands for Prescription Monitoring Program. Some of you guys have these amazing states that have been associated with all of these other states. So I might look it up in Arizona, and I can see what's going on in California and Iowa, et cetera. Some states are restricted just to their states. So it might be easy for the patient to get a prescription in Texas and then go back to Kentucky or vice versa. Okay, so just realize that you can get things out of state. Of course, I live in a border state, so you can get stuff in Mexico, et cetera, and you can get stuff on vacation or for friends. So this doesn't show everything. Now the question is, do you always review it when you get opiate prescriptions to somebody? And the short answer is the best practice is you should. I know it's a pain in the butt. A lot of you guys don't like to do it, okay? I work in a place where it's very easy to do. If I'm going to prescribe opiates to you, there's a button that I click, and I'm already logged in, and it kind of goes to the site, and it'll look it up for me. And in fact, when I go to print my prescription for an opiate, which I rarely do, it'll tell me, did you check the PMP for this patient? So it requires me to do it. It's not a hard stop, but it's what we call a soft stop, a still electronic medical record. It's still an electronic prescription, which these have to be, as far as I know, all states do electronic prescriptions for opiates now. Do you look for stuff that's, any inconsistencies? Any inconsistencies exist? Does something occur where the patient maybe was getting too many refills, running out sooner, all other new medications kind of came in? But, what was the easiest plan? What was the easiest plan? Unfortunately, the easiest plan is not the best plan. The easiest plan would have just been like, you know what? Here's my prescription pad. Why don't you tell me what you want? Okay? Maybe that's easy. Maybe some of us think that you're going to get better ratings on Press Ganey scores, et cetera, but not the best approach. You have to check these things. And if you get somebody that has no inconsistencies, and you feel like, maybe they do really need a refill and you've done your best, I have my personal rules. And I always say to the patients, I'm going to max give you 12 tablets of an opiate, okay? And then you have to follow up with your physician, et cetera. I've done the best to, evaluate it. And that's what I do acutely. That's what I might do in somebody like this who I see in an urgent care or emergency department or an office visit. Now, why do I do that? I have a magic number 12, so I know if the pharmacy calls me, they say, hey, Dr. LoVecchio, did you write this person for 200 tablets of OxyContin? I would say no immediately because I know I have a magic number. And the patient might say, give me more. And I say, you know what? It's against the rules. And they might say, one time I've been called out in my career where I've said that 100 times at least. And they said, what rule? And I said, it's my personal rule, my personal beliefs. And they usually back off on that, right? We all have personal beliefs. So tapering opiates. When do you consider tapering opiates? In the first guy, Mr. Obvious, it was so obvious that you taper opiates on him. In the second person, you were looking for inconsistencies. Maybe you found them, maybe you didn't. A little bit more subtle, a little bit harder to do. So when? The short answer is when people are misusing them or the drugs are doing no more good. Okay? Those are the two main points that you got to. So there's all of these reasons, and I'm going to go through them. The pain improved. If the pain gets better, why do you still need opiates? Okay? You should try to take them off. And what I like to tell patients in the emergency department is opiates really stop working after about 3 days at the same dose. You start to develop some tolerance, and when you start to develop this tolerance, the same dose is really not going to help you. And I also say that it's very, very, very rare for you to become addicted after only 3 days, okay? Now, if we said 3 weeks, that's a different story. It's very rare for you not to have some degree of physiological addiction after 3 weeks of opiates. Sometimes the patient requests. Now, in my experience, that doesn't happen all that often, but some patients do come to like outpatient rehab, et cetera, and they do have requests to kind of cut down on opiates. But people have done surveys. So surveys are kind of, a little bit different than real life. And when they've done surveys and they ask people who are in methadone clinics and they say, hey, would you taper off methadone? Would you like to taper off methadone? And in surveys, about a quarter of them say, yes, I wish it was offered to me. I wish doctors would give me that, okay? So maybe we should start asking more, okay? The other time to taper is when higher opiate doses have no benefit. You've increased the doses of opiates, but there's no benefit. The patients aren't getting better with that, okay? The other obvious one is evidence of opiate misuse. Now, what's opiate misuse? Opiate misuse means that you're not using it as prescribed, period. So does that mean that I can take my significant other's Tylenol with codeine and hydrocodone and throw it in? Does that mean I could have 2 shots of tequila and also take my OxyContin? No, that's misuse, okay? Does that mean I, want to get immediate relief so I crush it up and snort it? No, all misuse. You should ask about those things. I like to say things, oh, I see you're prescribed 1 tablet every 6 hours, Wow, that's reasonable. Are you taking it more often than that? And many times patients will kind of fess up and tell you that, especially if you do pill counts. Those of you in pain management, maybe primary care, and you're prescribing these medications, you really got to get into the habit of doing pill counts. Letting them know when they leave the door, say, hey, bring your opiates in, and we'll do some pill counts to make sure that we're on track here, okay? Obviously, if you gave them 30 days worth and they come in on the 31st day, that's probably okay. So the other thing that you think about is the side effects that diminish the quality of life and, impair function. So think about that, and it's really, really, really fascinating what happens when you take an opiate. And what happens when you take an opiate, I start to take it, and it causes the release of a magic chemical that we all strive for. We strive for it when we're trying to have sex and we're trying to see a great movie and we have a thrilling ride that we go on, and it's dopamine. So it raises levels of dopamine, and people love that feeling. But over time, okay, it changes the number of dopamine receptors, okay, which means you need more and more of that stuff to kind of activate the dopamine receptors, okay? But there's a counter hormone. Noradrenaline. And noradrenaline, those receptors get less, okay? And then all of a sudden you stop the opiates cold, okay? You stop the opiates cold, and all of that noradrenaline stuff is going to cause you to be, have all of these side effects that we're going to talk about a little bit later. But what are some side effects you might see? A common one, is constipation, but one that frightens me, of course, is impairment. You might be taking too much opiates, you might be impaired at times. I always tell people who are on opiates not to drive, okay? Do I make exceptions for that? As far as I know, I haven't made any exceptions. I tell them not to drive, even if they're on chronic. Now, I know the people in the back row are trying to throw something at me for saying a statement like that, but that's my general practice. I tell them not to mix it with any sedating drugs, etc. Okay? I tell them not to mix it with alcohol. Okay? And if you have unclear benefit, if you have a patient that hurt their back, they're in a car accident, when they were 25 and now they're 65 and they've been on chronic opiates, it's probably, not working. You should pursue a little bit more into the diagnosis. What if the patient experiences an overdose or a serious event, okay? And, that begs to say, hey, look, you took an overdose, you had this mishap, et cetera. Maybe it was accidental. We have to change your medications. Now, you don't want to just say cold turkey. I know I've been following you for 2 years for your pain, and I've been prescribing opiates for 2 years. You promised me you weren't going to take an overdose, and you overdid it, and you mixed it with these other drugs that I told you not to. If you stop them right there and say, no more opiates, okay, what do you think the chances of success are for them? The chance of success for them to not do anything else is close to zero, okay? So they say that, 90% of people who are forced to stop, forced to stop and something like that, if they have the opportunity, assuming that you're not in prison or someplace where you can't get opiates, 90% are back on opiates within 1 month. So it's probably not going to work, okay? Also think about tapering opiates when they're on other medications. The big one is benzos. We don't like that opiate benzo combination if you could avoid it. Have I ever given opiates and benzos to someone? Of course. Do I do it every day with sedation and, when I'm consciously sedating somebody, maybe trying to put a joint in or something like that got dislocated? Of course. Do I occasionally give it for acute back pain? Yes. Again, my practice, no more than 3 days, no more than 12 tablets. The combination, just be aware of. Now, people say to me, well, I want a muscle relaxant and Valium or, Ativan or lorazepam is the best muscle relaxant. And I say to you, you realize that it's not truly a muscle relaxant. If we took a biopsy of your muscle, it's not more relaxed when you're on these medications. The premise of these medications like the benzos, et cetera, is to put you to sleep. Okay, it puts you to sleep because most acute back pain, people predict about 80% of all acute back pain resolves in about 3 to 5 days, with or without treatment, okay? And a lot of you guys are nodding your head. Thank you for that. You're nodding your head because sometimes you throw out your back, you feel terrible for a day or two. You might take some non-steroidals like, most of us do and during acute back pain, and then it's over in a couple days, okay? And the whole idea is, well, if we can get you to sleep, get you to sleep, get you to relax, maybe things will be better and those 3 days will kind of go a little bit faster. And we've learned over the last decade or more or so that sleep is probably as important as medications, as diet in some instances, right? Okay? Not sleeping is like the new smoking, right? You got to get good sleep. So what about the patient whose medical conditions change, okay? And I think that's very, very important. Sometimes I see a patient who's chronically been on medications and they come in and they have obstructive sleep apnea, they have worsening COPD, okay? And then the one I absolutely, hate and see all too often is somebody who falls, okay? You see elderly folks who are on a little bit of benzos, a little bit of an opiate, their fall risk is very, very high, okay? And then you might even throw, a 10A inhibitor or an antiplatelet drug or an anticoagulant, okay? You really, really have to think long and hard of, am I doing good to this patient? And try to take them off these sedating medications, i.e. the opiates and the benzos, okay? We see that patient in the middle there walking up the stairs, walking up the stairs with a cane and using her arm to hold up the rail. I mean, that patient is not a good candidate based upon what I see right there for opiates, and you should really, really consider tapering them. All right, so opiates should not be tapered rapidly or discontinued suddenly because there's a super, super high risk of withdrawal. Now, I say that. That's not a catch-all statement. That's not for every single person known to man. If you use them for 3 days, you could just stop it, okay? But if you're on it for 3 years, you got to go really, really slow. You're probably doing nobody any good if you go super fast on those patients, okay? And I'll give you like general rules to follow, okay? Okay, now we see this poor person there, the animation there, okay? They have muscle cramps, they have diarrhea, they have some tachycardia, they have sweating, okay? They have, quote, goosebumps or piloerection. Now, a lot of people say, oh, this patient's faking, okay? This patient's faking withdrawal because they want more opiates, right? And I see some of you guys nodding your head, that's right. And it's very, very hard to fake goosebumps or piloerection. So I know all you guys are trying there, okay? That person in the second row thinks they have goosebumps. That's very funny. No, you don't have goosebumps. You're just cold, okay? And the muscle cramps. And people, when you talk to them, it's always fun, I think, you guys, when you're treating, a patient who's addicted to opiates, maybe you're treating them for something else. Maybe they fractured a bone or something like that. I really find interest in asking them about their withdrawal, asking them when they first started to use, how do they feel? Remember, these people, many of them, started to use because we prescribed it as clinicians, but many times they used it and it felt great. They had that dopamine rush and it was the greatest feeling in the world, okay? And, remember, fentanyl is so quick acting, very, very similar to heroin. before you have a couple beats in your heart, 3, 4 beats, it's in your brain almost instantaneously. When you smoke it, almost instantaneously, less than 30 seconds to start to enter your brain, okay? And an addict, many times, is trying to get that high. They're trying to get higher and higher, quicker and quicker. So that's why they kind of escalate the doses sometimes. Now, I ask you, all you guys have been sick at one time in your life. Probably many of you guys have had COVID or the flu in the last 3 or 4 years, and you felt like crap, okay? Somebody says, how did you feel when you had COVID? I said, look, I felt like I wasn't going to die, but I felt like a bus hit me, okay? I had a little bit of nausea. I was cold. I was warm. I felt like I was going through menopause. No offense to people who have gone through menopause. I don't know what it's like, but people describe it as hot and cold flashes. You couldn't get warm. You couldn't get cold. It was just ridiculous. I didn't want to eat. I had abdominal pain. I had cramps, etc. And somebody whispers in my ear, say, hey, walk outside and I will give you one pill and this will go away in 30 seconds, or this will go away within 30 minutes. Would you do it? Oh yeah, I would do it, okay? So just realize that when you have a patient come in unconscious, comatose, and they got a little too much Narcan from emergency medical services, or you gave them a little too much Narcan, they're withdrawing, okay? And you say, okay, just go home and don't give them resources. Don't try to hook them up with, medications. You've probably done them no good. And they are probably going to use again. And they're going to use again because they are sick, okay? And this sickness is described by many patients as the worst flu you've ever had, okay? All right, so risk of rapid opiate taper. I've kind of alluded to this. You can get acute withdrawal. Acute withdrawal nobody likes, okay? Now, people say to me, well, from opiate withdrawal, how about this? When you take opiates, how many people have died, okay? And I've been given this talk right now for about 30 minutes, okay, give or take. And since I've been given this talk, about 6 people have died in America. Give or take, somebody dies every 5 to 8 minutes in America from an opiate overdose. Pretty tragic, okay? How many people have died from opiate withdrawal since I've been given this talk? That's right. I mean, all you guys are saying together, 0. That's right. So, we always say no one ever dies from an opiate withdrawal, but you're going to feel like you're going to die. And there is a very, very easy cure just to take more of the opiate. That's what people do on their own. And that's why we should learn about these medications that we heard in this course and try to use them more, okay? We've been empowered, all of us have been empowered by the federal government to be allowed to give, great drugs like buprenorphine that we'll talk about some later. Risks of these opiate tapers, of course, if you just go too rapidly, is more likely than not, patients are going to seek other sources for it. Everybody knows about the person who's chronically on medications, chronically on a prescription medication, and then goes out and becomes addicted to heroin, okay? And nowadays, although heroin is still in our supply chain of drugs, most of that heroin's been replaced by fentanyl. And what do you think is going to happen when they shoot up fentanyl or they snort fentanyl, okay? I bought it from one dealer, and when you look at these pills, sometimes they have 10% pure fentanyl. Other times they have 90% fentanyl. So it's all over the place. In the drug dealer world, there isn't a lot of quality assurance, okay? There isn't an FDA looking at the medications, trying to see what percentage of meds are in there. So you might buy from one dealer and it's 90%, okay, and then the other dealer is like 5%, and that's why people get into a lot of trouble, okay? There's no quality assurance in that. Totally recommending that if there's a risk for acute withdrawal, patients are very likely to go back on their opiates. So you got to go really, really, really slow. Below there, people talk about, advertising, and I know there's a lot of companies that got a lot of bad press recently because, in the 80s, 90s, it really escalated the advertising to doctors to prescribe these medications, okay? But it's been around for a long time, and you see something from about the 50s or 60s or so where they're talking about methadone, methadone for treatment. So opiate advertising has been around for a long time. Opiates have been around for 3,000 years. Egyptians used the opiates, right? They used opium to get high. They knew it was a pain reliever, okay? And if you think about a Greek god, is it Greek or Roman? I apologize. Morpheus, okay? I know he's the guy in the Matrix, okay? Named after morphine, right? Which comes from the poppy plant, okay? Opiate tapering suggestions, okay? This is not an absolute rule, okay? These are just guidelines, okay? Consider opiate taper for patients who are on morphine milliequivalent units greater than 50 or so, greater than 50 a day, okay? How do you figure that out? Okay, it's very, very easy. You know, one of the famous lines that everybody always says, there's an app for that. There's an app for that. You can just go on the internet, etc. One of them commonly used is MD Calc. MD Calc, you probably know that one, okay? I'm not advertising for them, but I would if they asked me to. So why is it that these 50 to 90, is that a magic number? Well, in general, people have made differentiations that if it's over 50 versus under 50, you might be 7 times more likely to die of an opioid-related death, okay? And people are gonna, shake their heads and say, well, that was a retrospective study, that was in, this subpopulation of just, men, et cetera. And I agree. Not all of these studies are perfect, but I'll also tell you this. I can't prospectively get 100 volunteers and tell them to say, hey, do you mind taking like 90 milligrams of opiates a day and I'm just gonna follow you and see if you die? No, you're kind of stuck doing these retrospective studies, especially with something, as tragic as death. Okay, the beauty of these studies, though, is some of them, especially from other countries, they have one pharmacy that they go to, one hospital that they go to, and the reason for that is because they have this big government plan where you can kind of look up all the databases and try to mesh them, unlike ours. So frame the conversation around tapering as a safety issue. Okay, so I think you have to do that. You have to, tell them why. Okay, so I am constantly having the conversation that says, wow, did anyone ever tell you that you have all these, these opiates, and if you mix them with other stuff, you're more prone to death? Okay. Sometimes I say with somebody else in the room, just so they know. And we would like to taper you. Now the patient has to have buy-in. If the patient doesn't have buy-in, it's less likely to be successful. Okay. Determine the rate of taper based upon the degree of risk. Okay. So you don't need a rocket scientist to say that if they've been on it for a long time, they need a slower taper. If they're on long-acting medications, they need a slower taper, okay? So what's a long time? Well, we talked about 3-4 days or so that you could probably just stop abruptly and everyone be okay. Okay, if it's over a year, you gotta go really, really, really slow. There's general rules that people go by, 5 to 10%. Okay, there's a little bit of a range, but in my mind, I usually remember about 10% per week, and I'll show you that there's an overlap for that. And a little bit slower for someone who's been on it for over a year, and maybe around that for somebody who's been on it short term. Set expectations and a timeline. Okay, what really happens early on is when you cut down the opiates, your pain might come back and it might be more severe. Tell them to bear with you. Okay, that's a normal response. And a lot of people talk about this hyperalgesic effect. And when you think about this, I don't know if you guys have seen this before, okay? You have somebody, you say, hey, what's going on? Oh, I got a cough, pneumonia, tell me about your social history. Oh, I shoot up fentanyl and heroin 5 times a day, okay? And I say, okay, that's great. And let's start an IV on you. And you start the smallest IV you can find, okay? And you smart this, 20 gauge IV, and the person is screaming as if they're delivering a baby through their elbow. They're like yelling, oh my God, oh my God. And when I was younger, I used to say, oh my God, that guy, he shoots up with needles all the time, and now this little needle does that. And it turns out that's true. They're very much more sensitive to pain, okay? And it sounds absurd, and they're still sticking needles in them, even though it causes that much pain when the needle goes in, okay? Their pain receptors change, okay? And that's gonna come back though. It's gonna come back. If you've been on opiates for a year, it's gonna probably take at least a year to come back. Tell them to be patient, okay? So much of this is setting expectations, telling the patients to be patient, tell them why you do it. So longer acting, slower taper. Use a calculator to kind of get you to morphine equivalent units, okay? And we do that just so, we're kind of talking apples to apples, okay? And longer acting opiates decrease total daily dose by, 5 to 10% of initial dose per week, okay? And the shorter acting ones decrease the dose by about 5 to 15% per week. So what do? I do this technique called mental economy because I forget everything. And I usually just say, I'm going to decrease the dose by 10%, okay? And then I say to myself, oh, they're on longer acting ones, so I'm going to go a little bit slower than 10%. Okay, they're on short-acting ones, so maybe I could push it and go a little bit faster than 10%. See patients frequently during the process, and then stress behavioral support. It turns out that medication adjuncts help, okay? Also medication adjuncts with psychotherapy help even more, okay? Consider doing urine drug screens depending on your practice. Consider pill counts, and then of course the PMP, looking patients up. All right, consider adjunct medications. We really come a long way with adjunct medications. And when you're tapering somebody off, you might consider putting them on antidepressants. A common antidepressant used is amitriptyline. Amitriptyline, we remember, as a tricyclic antidepressant. And one of the reasons why tricyclic antidepressants might have a place in this is they do increase dopamine, but they also have some anticholinergic effect, which might help you sleep a little bit, okay? We know gabapentin maybe does a little bit of benefit. Non-steroidals, if it's not contraindicated. Clonidine. I also like to say clonidine and thiazidine, which works very similar to clonidine, might actually help with some of these withdrawal symptoms. Some anti-nausea stuff. I know sometimes we give Zofran or ondansetron. And in my experience, I find that ondansetron doesn't work as well in these patients. Maybe the nausea is too severe. I tend to give something else, like promethazine or something like that, because I like the sedating effects also. Anti-diarrheal effects. There's been studies looking at, good old Imodium versus Lamodal, and it turns out Imodium seems to do just as well, okay? I'm sure you guys have seen some case reports in the literature where people actually injected Imodium, okay? Imodium is a very weak opiate, okay? Very hard to get high from Imodium. I've been showing you all stuff that, advertising, and this is somebody advertising an alternative to, I believe it was morphine, which is heroin, okay? And if you remember the drug company Bayer, okay, the same year they released aspirin, which we still use today, aspirin, okay? They also released heroin, okay? 2 analgesics. Isn't that interesting? Okay. Interestingly enough, both of them are around. One's kind of illegal, one's kind of legal. Now, there's all these guidelines that come out, okay? And this is kind of a busy sort of slide, but it kind of tells you that, hey, your patient comes in and what's the risk-benefit ratio? What's my risk-benefit ratio? Well, when I think about my risk-benefit ratio, does it make sense for me to add on another drug during their taper? You got to document their benefit. And if you see what happened there, I had something enter there. And what I had enter there was the fact that you don't need an X waiver anymore. So overnight, they passed legislation that physicians, APPs, et cetera, can prescribe buprenorphine, okay? Remember, you had to take an X waiver, maybe you had to be addiction certified, but now you don't have to. So that is much different, okay? You do have to take courses like this or so when you renew your DEA number, when you renew your DEA license, okay? So remember, those adjuncts in certain populations, are going to help, okay? And what I mean by that is drugs that you've heard about in this course, such as buprenorphine or methadone, okay? So there's non-opiate alternatives, okay? And I have a list of them. One of them is acetaminophen. Of course, too much acetaminophen can cause a problem. And if you're in a lot of pain, maybe acetaminophen won't cut it. Nowadays, we have intravenous acetaminophen, which I almost never gave about 5 years ago or so. But now I tend to give more because the cost has really come down of intravenous acetaminophen. Okay, we also see non-steroidals, okay? And I love some of the topical non-steroidals that are more readily available, okay? I hope their cost comes down. Okay, we also know about like ketorolac, which we could give intravenously or so. We talked a little bit about amitriptyline, which kind of helps you sleep a little bit. Lidocaine, I think, certain drugs like lidocaine and capsaicin, try to use those especially for musculoskeletal pain, where you can kind of put them topically. Lidocaine works great. Now, I work at a county facility. Sometimes you use the 4% patch, which is great, but they charge so much for it. What I do, for my patients, sometimes I'll use lidocaine gel, which is a little sloppier than the patch, but it's much more cost effective. You might use gabapentin or pregabalin, which are very similar drugs, obviously. okay? And those are things that you think about. I enjoy capsaicin in the sense that when you put capsaicin on somebody, it causes a lot of pain. And the reason why it causes a lot of pain, it causes release of substance P. But then after you get used to it, it takes a lot to hurt you. In other words, it resets kind of your pain fibers. We see it lots of times given for things like trigeminal neuralgia or so. But you can think about it. I'm sure some of you guys use it for hyperemesis associated with marijuana use. So rest, ice, elevation, topical NSAIDs, capsaicin, lidocaine we kind of mentioned. But now look at this. Even your local pharmacy will sell you something like a TENS unit. Okay, TENS units are very effective. These for musculoskeletal pain in the right situation. The beauty of a TENS unit, if it fouls, what's the big deal? There's very, very, very little harm in that. Okay, with the exception of going through an airport and it buzzing. I mean, there's very, very little downside to using a TENS unit. Okay, one of the things we have to learn though is that there are alternatives out there besides what we do in Western medicine. And I think you should take a look at acupuncture. Okay, consider acupuncture for acute back pain. There's things that I don't do, but I think some of you guys have done, which is like radiofrequency ablation to your nerves. Okay, obviously, great things like yoga, which kind of benefits your mind, because a lot of this is, you do need mind benefit. Okay, some people use nerve blocks, which are also great, obviously in the right situation. Sometimes, if it's a joint that's involved, you might inject the joint, etc. So we talked a little bit about TENS units. We talked about physical therapy, of course, and therapeutic massage, okay? So a lot of this stuff comes down to common sense, the non-opiates, okay? The non-opiate use, okay? Just think about it, okay? Most of those things that we have listed here have very, very minimal side effects. The radiofrequency ablation, I mean, if you're inserting something close to a nerve, obviously there's the risk of infection, bleeding, and that sort of stuff. But many of them, like physical therapy, massage, yoga, have very, very minimal downside, okay? So I want to give you some take-home messages. You have to be sympathetic, but you have to kind of be like a detective. Be kind, but be this kind detective, kind of like Columbo, just kind of slouch around, you ask some questions, and you kind of get some facts, and before you know it, you have a good picture. You look things up, Discuss reasons for tapering. I'm not tapering you because I'm scared I'm going to get sued. I'm scared I'm going to lose my license for giving you too much. I'm tapering you because I'm concerned with you. You came to me with a cough and I'm giving you antibiotics because I'm concerned that you have pneumonia. Well, you came to me with this complaint. I'm concerned that you're on too many opiates and it's associated with death. Okay? Now, I sometimes bring up facts. I say, look, somebody dies every 8 minutes or so in the United States, depending on how you count, okay? And, that's alarming, okay? And then I say, look, in the 25 to 45-year-old age range in the United States, the number one reason for death is drug overdose. And the drug overdose, most commonly, is opiates. And when I say overdose, it could be accidental, okay, or on purpose, or voluntary, okay? Start slowly. I remember the number of 10% per week. Remember, you might even go slower if they've been on it for very, very long. Could you imagine somebody's been on, 100 milligrams of methadone for 10 years, and for whatever reason you guys decide that they're going to come off of it? Do you think if you stopped it in 3 days, they'd be okay? No, they would be in rip-roaring withdrawal, okay? A patient who's been on it that long is going to take sometimes a year or more to get off of it, okay? That's for, the exceptions there, okay? So just think about going, 10% or less per week. When I see somebody who's been on an opiate for a month or two, okay, and they say, hey, I'd like to get off of this. I want to go slow. I want to minimize withdrawal because I tried to do a cold turkey one time. I got rip-roaring withdrawal, very, very unhappy. And that was worse than anything I had when I broke my leg, etc. And I say, okay, you've been on it for 2 months. We're going to go 10% a week. Okay, give or take. We're going to count your morphine milliequivalence units. I see that you're on 100 milligrams, just to make my math easy. Okay, then we're going to go, we're going to drop you down 10% to 90 after about a week. Okay, then we're going to drop you to 81. Okay, then we're going to drop you a little bit less in the 70s or so. And you see what happens there. It's not going to just take, 10 weeks. It's going to take a little bit longer than 10 weeks. And what do you do when you drop the doses? Do you just say, okay, I'm going to eliminate the nighttime pill, the daytime pill? Okay. The thing that you do first is, let's say I took 2 tabs 3 times a day. The first pill you take away is one in the middle of the day, okay? The last pill you take away is the nighttime pill, okay? The last pills you take away is the nighttime pill. The other thing you should think about is, once you start taking the pills away, first you drop the doses. You might take away 1 pill, in the middle of the day, then you take away 1 pill in the morning, then you might take away 1 pill at night, etc. And you kind of do that. And then before you know it, you're on 1 pill 3 times a day. Eventually, once you get really, really low, then you might be on 1 pill in the morning, 1 pill at night, and then just 1 pill at night, okay? So first drop the dose and then extend the time, from TID to QID or Q 6 hours. Set expectations. And that's a good message for life too. Much of life is setting expectations. Remember, there's adjunct support, okay, and other medications that we could use. None of those medications are perfect. The closest we have to a perfect drug for opiate use disorder is probably buprenorphine. Not for everyone, okay, but buprenorphine has a lot of advantages, and we'll see more and more of us prescribing it. So I wanted to thank you, okay, and I appreciate some of you guys staying awake. I see 1 or 2 of you guys fell asleep there, and a couple of you guys had a good lunch, which makes me very, very hungry. Thanks for sharing. Okay, thank you so much.